more detailed information. But generally, people compared the diagnosis of getting dementia to the diagnosis of receiving support from cancer, and noted that it was really incomparable. People really struggled to feel that they had the same level of support they're dealing with a similar life-changing illness. But also, people were quite frustrated at not being able to access the health services the way they wanted to. People felt that they wanted to change their emails and change an appointment, and they found that changing those appointments and the administration of the whole process making appointments really didn't contribute to their well-being. I think one of the things that we were not surprised by, but still were quite disappointed, was that regardless of what language people spoke, people were only ever offered guidance in English. We couldn't find anyone who we spoke to who was offered guidance in another language. And so people also found it quite difficult if they weren't necessarily born in England and they were trying to navigate the health service. I think most of us find it quite difficult at times anyway to navigate through this process. So what we want to do is not necessarily do a lot of talking. We want to hear about people's experiences. So could I invite Debbie and Kate and Debbie again? We've got two Debbies. We were going to have Ashok with us today as well, who's living with dementia, but unfortunately he's not very well. So we want to wish Ashok, hopefully he's watching, all our best. And thanks to everyone on Zoom who's coming to join us. So you'd like to come and join our seats.
Thank you.
So I think what we'll go through is we want to hear your experiences. So Debbie, you've been diagnosed with dementia. What was it like when you had that first diagnosis?
Like someone had dropped a brick on my head, really. I knew something wasn't right in here. I had a good job in the city. Obviously, I'm not working in the city now. But yeah, I had a good job in the city. And I knew that there was something that wasn't quite right. You know, I was losing things all the time. Like I knew I put it there, but I didn't have put it there. All things like that. And then when the more you beat yourself up about it, the worse you get. And you just think, is this, what is this all about? I know I put that thing there and this, that, and the other, but with the help of my my group, they've become friends or family, because I mean, it wasn't easy because it was in a care home, and there were a lot of people who were quite unkind, and I'm not a shrinking violet. I come from this side of the river. So, but when you get people being nasty, oh, what you lost today then, like really unkind, but I can give as good as I get. But I used to think, I'm sure I did put that there. But through being nurtured by people like Zara, my family have been brilliant. I've had a lot of support that I know that other people haven't been lucky enough to have. I've been one of the lucky ones, I think. I'm not lucky, but lucky. Yeah.
Well, we really appreciate. Thank you very much for sharing that thought. Yeah. Now, I remember when we spoke before, you were saying that you knew that something was wrong.
Yeah.
But it still took a while for you to get a diagnosis.
Yeah.
But then, even when you got the diagnosis, you said it was like a brick hitting you.
Yeah.
So, if you expected it was going to happen, and it still hit you like that, it must be quite difficult if you're not expecting the diagnosis.
No, exactly. I thought they were my kid. I thought they were. It weren't. I didn't think it was true. But I've through all the care that I've had, I'll never give up, ever, ever, ever. I won't give up. And I've got a decent family around me, my children, my grandchildren. I've had I'm one of the lucky ones. Not to have dementia, obviously, but I'm one of the lucky ones. I still talk too much, still run around too much, but it's not a death sentence. There's so much help out there. You know, the care I've had from Bromley Council, Zara, who's been one of my supporters, my family. Sometimes it's difficult for the family because they go, "Well, what if you lost now then?" But they don't do that anymore. But yeah, it can be conquered. It can be conquered. Don't give up.
Thank you very much. We really appreciate that. Thank you for your comments. We really appreciate that, Debs. Okay, you can stay. It's fine. It's fine. You can stay. Thank you. I'm just giving you some more time because you're stepping in for Ashok. Kate, could you introduce yourself, please?
Yes, I'm Kate White. I'm here in my capacity as somebody who looked after John, my partner, for many years, diagnosed with Alzheimer's in 2009, jazz pianist, and we lived well with dementia at home until he went into a care home 3 years before his death, which was 2 years ago. So I'm here to kind of share experiences of a journey which, like you were saying, I feel fortunate in what happened to me.
So what were some of the issues that you felt that were coming across when we had our conversation before?
Yes, I think the thing that comes over to me most is the kind of diagnosis that you were given, that somehow the way in which that is given is so crucial, and that it can be given in a way which is very dispassionate.
Yeah.
And doesn't have the sense of compassion and hope, because actually, whilst there's this is an incurable disease, and it is deteriorating. There are lots of things. It is a point of departure rather than an end in itself. And the point of departure is to explore new things and different things, provided you get the support. And I've got my care team here, and Dr. Joles was the person who conveyed the diagnosis to myself and my partner. And we were there with somebody who also was part of the memory service. So we were very lucky. 2009, I think it was a pilot at that time.
And you've been quite involved now with the dementia community, but you were saying that you find it quite fragmented now compared to
completely. I think the part of it which saddens me most is that there is an incredible number of resources and activities and projects and things to get involved in, but actually they seem to be very hidden from those who really need them, and somehow the breakdown of communication, despite navigators and social prescribers and so on, they're maybe a bit like unicorns, kind of, where are they? And I think the mapping of what's available, and I was very fortunate to have Camden Carers help me point me in the right direction, and was part of a project which sustained community, because I think one of the things which I think you've identified too is the need to be in an ensemble of care, that it's not up to one person or one project. It's about having an ensemble around you that can support you, and so individuals don't get exhausted. And I think the other thing about fragmentation is that hopefully with AI and chat BT and things like that, surely we can get this together, that we can get a printout of what's going on around you, where you live right now. And just, leaflet distribution. I mean, we did this wonderful leaflet in Camden, but who's going to distribute it? We've had real problems. I've been doing the footwork, to community centres and GP practices, and we need to get the word out there, and we need to be on Good Morning Britain and Ed Balls. We need you. His mother has dementia, let's get him on board, and he might support us.
So a lot of the advice when we went and spoke to people throughout London said they got their carer centre was really invaluable to get that support, and that they really appreciated it. Maybe we could have a chat with Debbie. How do you? Obviously, you work at Camden, not Camden, at the carer centre for Barking and Dagenham. What are the common issues that carers really come to you with? What state do they?
Generally, we get carers that are in a crisis. More often than not, they don't start the beginning of the journey is not where we get them. We get them further down the line when they're in difficulty. As an organisation, we've been doing a lot of work recently. We're linking with the hospitals locally, and we're involved with them around the dementia nursing team. So we've built a good rapport with them. As well as the learning disabilities teams, etc. We're also advocating to all GB practices in borough. And as much as we do that, we still find that we're not reaching all the carers that are out in the community. And we find that quite frustrating, to be honest with you.
I can imagine. Do you feel that the connection between the health services and the carers services is something that happens quite naturally, organically, or is this something that really requires?
I think that we have to do a lot of the work to make us visible out there and let people know what we can do and how we can support carers, because the journey they're going to experience is going to be a very difficult one, and it varies from person to person, and some carers unfortunately can't cope with what they've got lying ahead of them. I think, you know, if it's a person that's been working and, you know, got an earlier onset of the dementia, that's even harder. And we do have cases where we lose carers because they don't look after their own health and well-being.
Yeah. Well, thank you very much for giving us this overview of London and what's happening at the moment with dementia care. We really appreciate your comments. Thank you so much. Everyone's safe getting off the platform. We spoke to Londoners and said, well, what is it that you want? And as Debbie said, even when you're expecting a diagnosis of dementia, when you get the diagnosis, it can feel like it's a bit too much to process. And so we co-produced a sort of a group with people, and they said to us what they really want is a 6-month review, so that after they have that inertial diagnosis, they can have time to process what's going on and understand the sort of questions they want to ask, and have this with a healthcare professional. As I said, the navigation services are great, they're fantastic, but what they need to do is talk about the health issue with a health professional, discuss medication, discuss advanced care planning, the sort of things that they would like to get the GPs to help them with, and to be able to understand really the process. And then someone they can have as a point of contact after they have a diagnosis. And actually, when we look to the guidance, we see that this is not a revolutionary idea or something that's really not been thought through, but this is actually something that has been proposed in the guidance, which we'll see next. At the Alzheimer's Society conference 3 weeks ago, Dr. Paul Giddy, as part of a panel, said, managing the dementia postcode lottery is a job for the ICS. It really requires someone to stand up and say, we can provide Londoners with a London offer for dementia. We took the opportunity to also see what the awareness was of what the actual guidance was in place. And it was staggering to see that 77% of people didn't know what the national guidance was, weren't aware of joint dementia research, and had not heard of strategies for helping their carers and their partners to cope with this diagnosis. Why is it important to have the NICE guidance? Well, that's what we're going to hear next from Jade Stacey.
Hi everyone, I'm Jade. I'm here from NICE. So I've come to talk to you today to give you a brief overview of how the NICE guidance can support high quality dementia care. So for any of you who don't know, NICE is a government funded body. We are asked by the government to develop evidence-based guidance on a range of health and social care topics. Our guidance is there to tell practitioners what the evidence says and what's cost effective in order to help practitioners give the best possible care to the people they're helping. We do that in lots of ways, but the two things that are probably most relevant to you today are our guidelines and our quality standards. So NICE guidelines are generally what's the best known. They're often very long documents and they cover a whole set of recommendations about a specific topic. So for example, dementia. They describe what good care looks like and also what cost-effective care looks like. Every single recommendation is based on evidence. And if you wanted to find out what the evidence was behind the recommendation, you can see it within the guideline. Moving on from our guidelines, we also develop quality standards. These are very different. They don't cover the whole topic, but instead they prioritise areas where the research tells us there's either poor quality care across the country or an unwarranted variation in care across the country. And so these are areas for quality improvement. They're priority areas. Both our guidelines and our quality standards are developed in exactly the same way. They're not made by NICE, we're not the experts, they're made by experts. So they're made by experts of experience, so people living, in this case with dementia, or their carers, and also experts by profession. So people come together, they look at all the evidence, they debate the evidence, and they come to a conclusion of what the guidelines and the quality standards should say. That then goes out to public consultation, and so everybody can get involved and can read and give opinions. And they look at the economic impact. And so for any commissioners in the room, that's also a really, really important fact that these guidelines are cost effective. They're the best use of very limited public funding. So why use our guidance? There's lots of guidance out there. Why use NICE? I would say the most important thing is that we know that if you followed NICE guidelines, you will improve the health and well-being of the people you're trying to support. There's not much more to say about that. But in other ways, if you have a NICE implementation process in your organisation that enables the use of NICE, you will have an evidence base to ensure that you're commissioning services and interventions that work and use public money wisely. It provides support for decision making at all levels. So from the frontline staff making a decision on their own in somebody's home to the strategic director making policies, it can help with every single decision. We can reduce variation and inequalities, which talking today across London is hugely important. It's not fair that the service you get in Islington with dementia is different from the service you get in Hackney. It's 10 minutes down the road. If we all followed the same guidance, everybody would be getting a fair service. And also it provides local accountability. If you know what you should expect from a service in terms of outcomes, it makes it easier for you to then hold those services to account. So what does our guidance say? There's a QR code on the screen for anyone who's fancy and wants to get a link to the guideline. But otherwise, you can find it on our website by just typing in NG97 or dementia, it will come up. So the NICE guideline on dementia addresses how dementia should be assessed and diagnosed. It covers person-centred care and support tailored to the specific needs of each person living with dementia. As part of this, it can help professionals involve people living with dementia and their carers in decision-making so they can get the care and support that they need. It also addresses care coordination and staff training and how dementia may impact on the care offered for other conditions. It's a very long guideline, so I haven't got time to go through it all today, but these are the headings of the recommendations. So as you can see, it's very comprehensive. No matter what part of the dementia pathway you're on, where you're working, you will find a recommendation that can support you. And it's for both health and social care practitioners. Then we have a quality standard. So just a reminder, these are priority areas for quality improvement where we know improvement needs to be made. And these are the statements. So there's 7 of them. If you're working within dementia care, I might ask you today to take away the quality statements, have a look at them. Does your service meet these? Are you doing these? If you're not, this is a really worthwhile area for a quality improvement project. It'll be one that is very impactful. So we know that these statements will contribute to improvements in the following outcomes: time from referral to diagnosis, hospital admission rates, prescriptions for behavioural and psychological symptoms of dementia, care home admissions, length of hospital stay, preferred place of death, health-related quality of life for the person living with dementia, and health-related quality of life of the carer for the person living with dementia. These will improve people's lives and they will improve your service and your budgets. And then lastly, we have a quick guide. So these are developed with the Social Care Institute of Excellence, and they are very visual, they're very simple, and they give an overview of what NICE has to say on dementia. The Dementia Quick Guide is aimed for people living with dementia and their carers, and it has information on what to expect after diagnosis, planning for now, planning for the future, and support for carers. This is free to download. All the feedback is that people like these. They're easy to read. You may want to think about downloading them and having them as part of the information that you hand out to people at diagnosis or at review. That is a very brief overview from me. NICE has a monthly newsletter. I would recommend you all sign up. There's a QR code again. If this allows you to keep up to date with everything that NICE has coming out, sort of related to dementia, but all of other guidance as well. My email address is also on the screen, so if anyone has any questions or would like support to get the dementia guideline fully integrated into your service, please give me a shout. Thank you.
Great. So thank you very much, Jade. And so you've heard a bit about how we heard from Londoners about what was working, what was not working in their journey with dementia. We've heard about what NICE has to say, and you'll see in some of the guidance and the quality standards, the things that are definitely relevant to the issues that that Ben was talking about and some of the proposals that we came up. And so for the next two presentations, we're going to talk about how we're going to turn these ideas into reality. So what would a really good offer for longer term post-diagnostic care look like from the NHS in London? So we're going to hear from Krish, who's been the clinical lead on this part of the project, and then we're going to hear from our colleagues Jen and Helen about the pilot. So Krish, over to you.
Hi, everybody. So my name is Krish. I'm a medical doctor working in Southwest London in older people's mental health services. I'm also a GP working in West London. And it's been an immense privilege to be part of this amazing project, listening to Londoners and their experiences of living with dementia. I'm going to talk to you a little bit about the key considerations and the challenges that we bore in mind when designing a commissioning framework for Londoners living with dementia after diagnosis. So, when we embarked on this project, we really thought about what would make an effective and sustainable commissioning framework. And we looked at the key metrics of successful healthcare commissioning. Ideally, it needs to understand and meet the needs of the population being commissioned for. I mean, that's a basic standard, really, isn't it? It needs to be evidence-based, and it needs to provide something that's easily delivered in order to be successfully implemented. And above all, it needs to provide value. And by value, I mean outputs achieved for inputs provided. And that can be economic. So obviously costs and saving costs, which is uppermost in many commissioners' minds, but also less tangible values. So for example, quality of life, reduction in ill health, and satisfaction in the people who are using the system, the patients, the people who care about the patients, and the professionals in the system as well. I want to talk to you about some of the challenges that we faced during the time frame of this project as well, and that we needed to think about. In particular, austerity. Sadly, in this country, we've had over a decade of austerity, which means that there's very little new resource. And again, of course, that's a key consideration for those who are commissioning healthcare services. Unfortunately, COVID has added another layer of complexity to that, and that's impacted disproportionately on vulnerable groups and minoritized groups. And that's particularly evident in London, which has a really diverse population. We were very mindful that our project would be under scrutiny as well. In this country, healthcare commissioning is funded via the public purse. And quite rightly, it's subject to more checks and balances and governance than perhaps third sector organisations or private organisations. And we needed to be mindful of that. We also were very conscious that London, despite the ravages of austerity and COVID, remains one of the great global cities. And commissioning in London, healthcare commissioning in London, will not only influence policy and health outcomes in London, but has the potential to influence healthcare policy and healthcare outcomes nationally and internationally. Believe it or not, our commissioning processes are envied by other areas of the world. It feels a bit ironic, I know, in the context of the current COVID inquiry, but it's true. And organisations like NICE are considered to be arbiters of best practice in terms of implementing research and evidence into clinical practice. And that's, again, something that the rest of the world takes heed of. So we were conscious of that. But the biggest challenge that we faced and we needed to address was the exhaustion of the workforce. And that's a huge, huge challenge. And by workforce, I'm going to clarify what I mean by workforce. Of course, we mean our wonderful frontline colleagues, the clinicians, the nurses, the pharmacists, the OTs, the physiotherapists, who all see patients face to face and have worked tirelessly throughout COVID. But I also mean what I describe as the back office teams. So I mean the administrators, the managers, dare I say it, the commissioners, who hold responsibility for the healthcare of huge swathes of the population. But above all, we are referring to this vast army of unpaid carers who I think constitute a huge part of the workforce that support people living with dementia. And we really need to be mindful of the fact that all these groups are suffering quite significant moral injury because they don't feel able to provide the care that they want for the people that they care for at the time that they need it. And that was so important to us. And how do we deliver a framework that actually supports all of these people within the system? So, moving on, I think Ben and Kate and the two Debbies actually put it far more eloquently than I could ever do in terms of what they needed and wanted. But we did map the current state of services in London. And we sought out insights and experiences from patients living with dementia and the people who care about them. We did it via Ben at Care City, but we were also very privileged to have access to research projects conducted in London by two of London's academic powerhouses, UCL and King's College. The PRIDEM study, looking at post-diagnostic support in primary care, and the Embed Care study, which looked at the palliative care needs of people living with dementia. And we were very fortunate that the researchers were generous to share some of their data and the insights that they gained from speaking to people living with dementia in London. So we pulled all of that together, and essentially post-diagnostic support in London is fragmented and sadly inconsistent. So how do we try and make that better? Well, we listened to what Londoners wanted. Essentially, they wanted agency, the ability to determine their own journey in their own time for as long as possible. They wanted consistency, and this was very interesting to me, actually. They wanted to have someone who knew them, or at the very least, an organisation that felt familiar to them. And actually, it was very interesting. They wanted to be anchored to the NHS, which surprised me in the sense that there's often, I think NHS services are maligned, but actually the overarching theme was they wanted to be anchored within the NHS. And above all, people had a need for connection, which sadly has been decimated throughout the pandemic. And connection worked two ways. So healthcare professionals and social care professionals wanted connection as well. And again, that was another real overarching theme that's been replicated, I think, in much research. So we listened to Londoners, and you'll be very relieved to hear that what Londoners wanted is very much evidence-based. They wanted a consistent point of contact. They wanted access to a healthcare professional and a forum to form connection and to have a health check and to be signposted to support services and counselling if needed and access to research. So we've put it all together in this rather lovely diagram here, which my colleagues will talk a little bit more about in detail in terms of how we tested the feasibility of this framework. But you can see people really wanted consistency, and they wanted to remain as independent as possible for as long as possible and know someone who knew them and form that connection. So I guess in conclusion, what we've tried to do is deliver a framework that's compassionate to people going through that system, patients, the people who care about them, and the professionals using the system. And we're hoping to do this by working smarter and providing a digitised and accessible record across NHS services, which all patients can access, with a consistent point of contact throughout that post-diagnostic journey in order to make life easier and a little bit better for everybody in the system. So I'm going to hand over now to my wonderful colleagues, Helen and Jen, who tested aspects of this framework with a fantastic GP surgery and staff in that GP surgery in Romford. Thank you. You don't need it, do we?
Good afternoon, everyone. I'm Helen. I'm an occupational therapist by profession, and I'm here with Jen, who's a specialist nurse, and we both work for the London Dementia Clinical Network. And we're going to tell you a bit about the pilot that we ran. So as Krish mentioned, we conducted the pilot in a GP practice in Romford. We had a nurse and a pharmacist who agreed to be part of this and to complete the reviews. We went in to give training. We spoke about the pilot objectives. We did some dementia awareness training, and we also developed an assessment template to use. And we asked the practice to do a search and identify patients living with dementia at different stages of their illness. This is what the review process looked like. So for the first 15 minutes, we had Ben present, who did the before review questionnaire. And what Ben asked the people living with dementia and their carers was, when did they last have a review? What were their expectations of the review that was going to be conducted? And what kind of support were they receiving for their dementia? Then they went on to have a 1-hour review with the nurse and the pharmacist, and either Jen or myself observed this review. For the final 15 minutes, they went back to Ben and spoke about how the review went, what the experience was like for them. Following that, the documentation had to be done, the necessary referrals made, completed by the clinician. And then at the end of the session, we held a multidisciplinary team meeting with a GP from the practice. We based our review template, we adapted it from the Camden and Islington Memory Service template. It was a health-based review, very comprehensive, addressing physical and mental health needs, looking at the patient and the carer. And we also asked about research, and nearly half of them were very, very interested in research and participating. Patient demographics, well, we conducted 15 reviews. 9 of these were completed in the GP practice, and all of those that attended the GP practice came with their carers. 4 of them were done in the care homes. We had no carers or relatives there. They were done with a care worker. And then there were 2 that were completed in the community, in their homes. And this is because they couldn't attend the GP practice. One of the people were bedbound, and the other couldn't leave the house on his own, and he had no carer. So they were seen at home and really appreciated being seen in their own homes. In terms of the ethnicity, so ideally, we would have liked to conduct this pilot in a more diverse area, but we weren't able to. We did it in Romford, and if you look at the circles, the outer circle is the practice. The inner circle represents a Romford ward at the same time. So you can see that the ethnic group that we saw largely represents the population in Romford. It's largely white British, mostly white British that we saw, and others. And then we did see a few more female than male, and that also represented the ward at the time. In terms of the time lapse from when they had their diagnosis, we saw people, 33% of those had been diagnosed just 6 months or just over that time. We had 20% that were just over a year. And then those that were in the care home had all had a diagnosis of dementia for over 3 years. I'm now going to hand you over to Jen, who will tell you more about the pilot and the outcomes.
Thanks, Helen. I'm Jen. Nice to see everyone. I'm just going to talk to you a little bit about some of the outcomes of the reviews. So just to start out with, this graphic shows you a breakdown of the length of time that was taken in the reviews. So they were mostly between 1 and 2 hours. The first day we had separate sort of appointments, for one with the nurse and one with the pharmacist. And we noticed that there was a bit of repetition, and it was taking quite a lot longer than we had anticipated. So after that, we decided to combine it and make it into a joint clinic appointment, and that worked much better. And at that point, they averaged at about an hour. So that was closer to what we were aiming for. Care home visits were a little bit shorter, so they were about 45 minutes. And one of the things that we noticed really that's important here is flexibility. So being able to take a bit more time with people who need it. We had, a lot of emotional conversations, and it was really nice to give people the time to talk about what was on their mind and what they were going through. And both patients and staff noted that it was nice to have that time as well. So in terms of the referrals that were generated from the reviews, there was 15 reviews and 18 referrals were completed. There were 2 reviews that didn't have any referrals, and those were people who were living in care homes. So it seems their needs were all being met by the care home, which is great. About 22% were social referrals, and that was anything from respite, package of care, key safe, and also social activities and groups as well. A majority of the referrals, about 45%, were physical health. So that was Some people were lost to follow-up during the pandemic, so it was re-referral back into services like oncology or cardiology, and there were other services as well. And then about a third were mental health. The patients in this surgery are quite lucky because they have a mental health practitioner actually on site, so they could just make appointments directly that way. But there was interest in support for mental health as well. So just some of the other outcomes. So 73% of the reviews had advanced care planning discussions, and this included anything from patient wishes, what are the things that they want about their care, discussions about ceiling of care. So if they want to go to hospital, if they become unwell, where they would want their care to, how far to go, ITU or a breathing machine or whatever it is that their wishes are, just exploring that. Also talks about CPR as well, whether people would want CPR in the situation of cardiac arrest. And probably the most common thing that was talked about was power of attorney. Some people had that set up, some people were thinking about it, some people hadn't heard of it. So that was really important to talk about. All the reviews included a pharmacy review, and 60% of those generated either advice or medication changes. So some of the examples of changes that were made were stopping omeprazole, changing medications to a liquid form for people with a swallowing difficulty, bone protection, treatment for a urine infection, treatment for high cholesterol and vitamin deficiencies as well. And I think one of the most important things that was focused on is the needs of the carers, and we asked the carers how they were doing and offered support in that way. And I think that was really appreciated as well. So we also measured the clinical frailty score of all the patients, and this is quite important because this indicates a higher risk of hospitalization, falls, extended recovery from illness, and so on. So it might affect what decisions you make about their care and what you recommend. And you can see here 70% of the people we talked to did have some level of frailty, so that's quite important. We also did a fracture risk assessment. So that I'm not going to say a whole lot about this, just that it turns out that 20% of the people it was recommended to just treat to start bone protection. So that could potentially prevent future fractures, which nobody wants. So that was beneficial. We also we offered blood tests to everyone. One patient had a recent blood test, so we didn't do one for that person. Out of the blood tests that we did, over half, there was an abnormality that was found that led to advice or a change in medication. So that was really important. Some of the things that we found were diabetes, vitamin deficiencies, and some other things. So that was quite important. One thing that we did note is that about a third of people didn't do the blood test, and we handed them a form and they were meant to go and organize the appointments on their own time. And for whatever reason, that didn't happen. And also we were also told that there was a delay in phlebotomy appointments as well. So it could be a long time before people actually were offered an appointment. So we did think that it might be beneficial, if possible, to have a phlebotomy service at the time when they come in for the review, because that means that you know that most people would have their blood test. And just to talk a little bit about the pre-review questionnaire that Ben did with the patients, there were a few questions that were asked about their experience of dementia care before the review. And you can see one of the questions was, how well do you feel supported with your dementia care? And you can see that more than half of the people felt unsatisfied or very unsatisfied, and most people said they would go to their GP. So there was a real lack of sort of specialist support and advice. And also a questionnaire was done after the review as well. And Ben asked, how likely would you be to recommend this care plan review to family and friends with dementia? And you can see here that most people said extremely likely or likely. And we received a lot of very positive feedback. You can see from the quotes here. I think everybody felt it was really nice to be supported and listened to, and it was overwhelmingly positive. So I'll just hand back over to Helen to talk a little bit about our reflections.
Thank you, Jen. So these are some of the things that arose as the pilot progressed. Just in terms of the staff training needs, we did communicate with them afterwards, and we think that on reflection, it might have been an idea if perhaps Jen and I, both being clinicians and having experience, having conducted these reviews in our clinical time, to perhaps have done the first session of initial reviews, just for training purposes. There were also a lot of emotional discussions that were had, and around a lasting power of attorney or mental health, and it might have been helpful to have a bit of training around that. As Jen said, there was a lot of duplication with the nurse and the pharmacist reviews, and so we combined those after the first session. The length of the reviews were variable, and one has to be mindful of that, and leave that time and space open, because it can differ. The blood results, as Jen mentioned, would have been ideal to have a phlebotomist present, because we don't know how many people go ahead and have the bloods done, and there are the delays. We saw the value of having a carer present who could give the collateral information, because it was quite hard with the person who didn't have somebody present. In a few reviews, the carers spoke about wanting time and space to speak freely and away from the person. So they would need that time separately with the clinician. We also saw the value of home visits, because there was no way that the two people we saw at home would have been able to come to the surgery, and they really appreciated that. Cultural needs need to be mindful and to personalize the sessions for people from different backgrounds. There was also the reality of inputting information while doing a review. So nobody felt comfortable having a laptop in front of them and writing things up while doing the review. So time needs to be put aside to write up the review following the assessment. We saw the value of local knowledge, just understanding what is available in the area. These things change, they're groups that come and go, and that's really important. But to end, it was just, we got really positive feedback about the reviews, and people spoke about how nice it was to be listened to. So in terms of our next steps, we want to gain input and your expertise here today at the event. We all want to work together to collaborate and to consider how we can embed this framework and launch it across London, so that everyone living with dementia has this support. Because we think that the outcomes will be very positive, that to have a named person, a named contact throughout the dementia journey will be of real value to the person living with dementia. There can be early detection of issues. This will prevent crisis situations. It will prevent admissions into hospital or sitting around in emergency departments. And it will also improve access to services, so that people will get the services they need at the right time, which will prevent emergencies later. So ultimately, we really believe that this will enable people to live independently in their own homes for as long as possible. So thank you for listening. And I'd also like to take the opportunity to acknowledge the Romford GP surgery. We have representatives here today, and we're very grateful that you were able to give us this opportunity. And thank you, everyone.
Don't get to escape that easy. Right, so now it's time for our Q&A. Are our two ladies from the front, because they, yeah, because Ben, I think you need a seat here too. Okay, I did see them sort of hover there. We'll just get them in so that we're ready. And they'll make a start. Before we start, I mean, just my reflections on this fantastic work is, you know, you've uncovered a huge amount of unmet health needs. I mean, were you shocked, stroke surprised by the amount of sort of unmet morbidity that people are carrying? Did that surprise you at all? I mean, you're both experienced healthcare practitioners.
Didn't surprise me.
Okay,
because I've
take the mic.
seen
Take the mic.
it didn't surprise me because I've seen it in my clinical work. I see it all the time. So it was, I think this GP surgery is exceptionally good actually at keeping an eye on its patients living with dementia, and you still found things. So yeah, I wasn't surprised because I know there is an unmet need out there.
I think also we have to keep in mind that dementia is a deteriorating illness and that things come up all the time, and they do need to be addressed as soon as possible, because then things escalate and then other complications arise. And I think that it reminded me of that.
I think what came across to me when we in the London networks talk with our other networks, we have a frailty network, for example, we have cardiovascular networks, is how you can't really, and you shouldn't really try to separate dementia from the other long-term conditions that people are living with. And so that when people come to talk about issues that are coming up as sort of living with dementia, they're also going to be coming with things to do with other health conditions, and you know, your everything is multiplied in terms of complexity, but you have to kind of be willing to look at a bit of everything. Okay, let's see if we have some questions from the floor. Lady over there.
Hi, I'm Sarah Addison. I'm the Dementia Services Manager for BRG Mind. I also run the Yoda project, one of the projects. I think this is, obviously, everyone will think this is brilliant, but how long will it take from where we're at now to get there? Because our clients can't even get appointments with the GP. They can't even get to see them face to face. So I love the vision. I just wondered, do you have any timelines for this?
I don't have timelines, and I'm not sure if my colleagues will be able to say, but I do feel that the GP surgeries will need a designated worker to be doing these reviews. I'm going to hand over to Chris, who also has a GP head.
Yeah, do. So interestingly, GP surgeries are actually providing more appointments than ever before, and continue to do so. In terms face to face, but also via telephone and online. For dementia reviews in particular, I think they need to be what that person with dementia needs, which usually is a face to face appointment. There's no doubt. And I think above all, people need time and consistency. And so, as Helen said, I think there will need to be someone either at the surgery or in another NHS context. We didn't say it had to be at the GP surgery, but what people wanted was to be anchored to an NHS organisation. I was really, I was surprised and in some ways pleased by that. You asked about the timeline. That's difficult for us to predict. And that's why we want your ideas about how we can embed this across London. But yes, I agree. It definitely needs face to face. Oh, there's more. I think someone else is asking. Yeah. So So in my service, I have to say, we've been the majority of our contacts with patients in our memory service have been face to face from about July 2020 when clinics were reopened. I am very conscious that that's not always the case. And I think our priority will be to try and support services to deliver what patients want.
Thank you. I'm going to move us on, but just a comment is the model that we've piloted here is a face-to-face model. So that's what we would be looking to get delivered, get funded and get delivered. And if you'll notice, it's using existing healthcare staff. So we didn't invent a new role or employ a new person to do this. We supported existing members of the primary healthcare team to deliver this intervention. Right, let's have some lady at the back there.
There's a couple of things that I'd like to point out.
Could you hold the microphone? Thank you.
There's a couple of things that I'd like to point out, especially in our borough. One is that the GPs are not helping a lot of the patients with dementia. And in fact, we as an organisation have had to go to the community treatment teams to actually even deal with a UTI. The other thing that I want to say is you're talking about the health needs of the person with dementia, but it's also lacking carers assessments in Barking and Dagenham. Every carer has a legal right to a carer's assessment to look at their own health and well-being, and they are failing in our borough.
Thank you very much. That's very helpful feedback. Gentleman at the back there.
Yeah, thanks. I mean, it's in the city in Hackney. We've had many of the findings that are the same as what's come up in this meeting, which is great. So I mean that, I really support the idea. It's a cultural desert after diagnosis. There is a need for a named person from diagnosis to end of life. There is a need for face-to-face and the voluntary sector. I suppose what we've been balancing, and Dr. Walid Fawzi is here, who is the clinical lead for the pathway. What we've been balancing in City in Hackney is how do you make that affordable? I mean, how do you cover the large numbers of people with dementia and the long journey from diagnosis to end of life? And I suppose one of our solutions was actually digital. So yes, we support face-to-face, but there had to be some kind of register of people, and also a care plan which is owned by the person that's held digitally on universal care plan, but also some kind of tiering or level of stratification. So people who are low input are risk assessed regularly and then may up. So not everyone gets like a maximum input. So you kind of use your resources widely. So I wondered about whether those ideas are part of the journey forward as well. Thanks.
That's a great question. I want to respond to that.
Yeah, I'll respond to that. You asked about how we make it affordable. I'd say how can we afford not to implement it, firstly. In our pilot, we did use existing frameworks. We tried our best to use what was actually already in the GP practice itself. We're not saying it has to be based in general practice. It could be via, as City and Hackney have done, a pathway held by the memory service. But we were trying to use existing resource, so an existing template. The London Universal Care Plan will be going live at the end of this year, and that's going to be across hospital settings and community settings, and hopefully that will reduce the administrative burden and the bureaucracy that so many people living with dementia have had to struggle with, and allow some stratification of support needs and risk as well.
But do you think that the sorts of assessments or reviews rather that we used in this pilot could be subject to a kind of a triaging process whereby you rate the acuity of need and the timeliness of any further review of the person? I mean, in community nursing, these approaches are used quite a bit, aren't they? Jen, is that fair? Do you want to say anything about that?
I mean, I personally think that everybody should have a yearly review, regardless of what their situation is, because it is a progressive disease. And I think they, at least every year, people should be checked in with. In terms of length of reviews, it's possible that it could be, that they're having more difficulties, so the length of review might be longer. But I personally think that every year, they should be checked in with. I know in some areas, a dementia service, I think a city in Hackney actually check in every 3 months. Some of it's telephone calls, and that's fantastic. But I think every year they should have a health review by a nurse specialist or a therapist, or so that's what I would say.
Ben wants to come in. Let's pass the mic.
I forgot what I was going to say now. No, I was thinking about how NICE have already done the financial evaluation. They go through months and months of processes to make sure that what their recommendations are checked, to make sure they are value for money. And when the question is, well, how can we afford to do this for people with dementia? Well, that question doesn't get asked for how can we afford to do annual health checks for people with learning disabilities? We don't ask that question. It's just part of what we need to provide, because that's what the guidance says. Well, the guidance also says we need to provide this for people with dementia according to the NICE information, but we're not doing it. So this is why I do have to reflect back that question as well and say, why do we make a distinction between dementia and other health conditions?
I'd like to, well, VIP here who's going to ask a question, but I want to bring in our online audience. So James, what have we got from them?
Yeah, we've got a couple of questions coming through from online. I think it's just touching on what Ben was mentioning there. So a question from Ellie is, how does your model align with the GP annual review requirement? Would this be additional or an improved version of the existing review requirement?
Get Chris to answer that.
So there is quite a lot of variability in the annual review provided for QOF, the Quality and Outcomes Framework. And certainly we would envisage that this is building on that existing review, in perhaps an enhanced version of that review.
Another question from Charlotte. Charlotte was wondering how oral health as part of wider systemic health and well-being is part of the pilot programmes in terms of supporting mouth care and ongoing oral health related quality of life.
Perhaps I'll pass this to my colleague next to me.
So we did include that in the review, and we did ask questions about that. Do you want to add anything, Jen?
No, I was just going to say the same thing. I think that's really important. It's something that we did include. I think that might have been the one thing that wasn't included in the EMIS template that we were using. So it was in addition to that, but it's obviously really, really important. So it is something that's part of the template that we created.
Now I'm going to bring someone else in the front here. This is Katerina Nolan. This whole project wouldn't have happened without Katerina, because she was the project lead for the network when Laura was on her previous maternity leave. And you can see she's about to disappear again. And it was Katerina's vision and determination that got this project funded. So, thank you for that. Anyway, what's your question?
That's all right. So my question is, and I don't want to put you too much on the spot, but obviously this was a feasibility based on stakeholder wants and needs across London. And it was done, these reviews were done by a nurse and a pharmacist from a primary care perspective. I know the data shows us that people in crisis living with dementia who often access emergency departments are doing so with a history of perhaps a urinary tract infection, so sort of infection in their waterworks, and falls being some of the two big hitters within that. And I couldn't help but notice within your data that you showed, and I'm very mindful it is a feasibility study at this point, is that there was some treatment interventions for bone protection and for urinary infection protection. Do you see there being opportunistic points there within these reviews that could have prevented crisis deterioration for those individuals had they not had this review, and would have potentially ended up, I may be answering my own question here, but
would have ended up with a hospital admission? And have you done any potential costings around that that could then be marked up?
I can comment on the one with the UTI. It was someone in a care home. They were considering putting her on an antipsychotic. And they, in the review, spoke about how she was having recurrent UTIs. And that was when I mentioned possibly a prophylactic antibiotic first to clear that, because they were saying, we've got to get her to the CMHT. I said, the CMHT will not see her until her UTI is cleared. And then we discussed it at the MDT. And I'm hoping that they put on the prophylactic antibiotic and possibly avoided CMHT and antipsychotic. I think the other one was one that you saw.
Which one?
Bone.
Bone protection. Oh yeah. So so we did a fracture risk assessment for everyone. And yeah, so there was several people who we started bone protection on, reviewing a holiday as well. So, and I think the important thing there is that they probably could have prevented future fractures, which obviously are costly, but also in terms of quality of life, we really don't want that to happen for people. So yeah, that was important. And also, you know, if it's a home visit as well, so a part of it could also be looking at the environment and you know, do a little mini falls assessment that way also. So that can be part of it as well.
Lady at the back, we're waiting patiently.
Thank you. I'm very concerned about a generation who worry about having senior moments, but actually are secretly worried that they actually are experiencing dementia. It is such a stigmatized area still. And I would imagine that nobody has the exact figure of how many Londoners are living with early stage or later yet to be diagnosed. And I think that part of what I would like to see is much better support for people to come forward, for people's families to be sympathetic, empathetic. How do we handle this and where does it fit in the framework?
Thank you. I hope the panel don't mind if I answer that. So in fact, we do have a rough idea how many people in London have dementia and don't have a diagnosis. And it's just over a third of people with dementia, we think. Or we're trying to improve the data that underpins those assumptions because it's a little bit rough and ready. So there are significant numbers of people without diagnosed dementia. And the process of getting a diagnosis is something that we have thought long and hard about in the clinical network over several years. It's not the focus of today's work, but what I would say that how it relates is that if we can show that as an NHS, we are genuinely going to care for people after they've got a diagnosis, and we're going to keep in touch with them, and we're going to hold them close during that process, then people will be more likely to want to start that process because we'll have reduced some of the stigma. So that's why I say how these things link together. At the front. Got one there.
Thank you. It's wonderful to hear all these contributions. I wanted to emphasize the social context that people are coming to you with, and I'm delighted people are going to be linked into the NHS, but also those who are doing the assessment to be wised up to the necessity for people to be part of the community in which they're living, and how is that being assessed in terms of their well-being, because many people say to me what matters to them is love, community, neighbours, friends, being part of things, not being isolated and shamed and hidden away.
Who wants to respond to that?
I'll start. So we spoke about that because we spoke about how important it is to know about what's going on in one's own community to be able to make the appropriate referrals. And I do know this practice has a social prescriber who is currently, I think, on maternity leave. But it is really important because there's such variation across London in terms of what is offered in the community, that it's really important that that community knows what is available. I don't know, Jen, if there's anything further, but there were referrals made into the community from there.
Yeah, and just to say that, I mean, not everything will work for everyone. So there might be some social groups that someone might know about, but actually that might not work for somebody. Maybe they want to do something else that's more specific to what their interests are. Or so I think really having an idea of what's going on in the area is so important. And also a lot of things are changing as well at the moment. So at the surgery, having a social prescriber, is amazing because they know everything that's going on. And I really think that's important.
Okay, so what I'm going to do, because we're reaching the end of our time, I'm going to get the questions online, then one or two questions from here, and then we'll get the panel to respond to them all in one go, right? So a big bang, and then we'll need to move on to our workshop phase. So, James, what have we got online?
So Temi would like to ask, given the majority of the sample group patients were from a white background, what differences might there be or could be anticipated from patients from minority ethnic groups?
Okay.
And then the final question, what sort of mental health input was requested during the reviews?
Okay, and then some comments at the front. So there's one about how we might make it culturally competent outside of a white British population, and one about what sort of mental health input was needed. Let's have some questions.
Thank you. Allegra Lynch from Camden Carers. I was really glad to hear you mention carers so much in all of that. And my question is simple. What more can we do in the third sector to support you?
Did you want to ask a question?
Yeah, it's sort of a bit of a comment and a question, really, going back to what Chris said about the use of enhanced service. I'm a GP. We do QOF dementia reviews of varying quality, I'm sure. But where there's been success with the learning disabilities and with mental health is because they have had funded, very specified enhanced services. So I think what we need is something for dementia that is measured, that is compared. At least if they're done, that's a start. Then how you deal with the quality of what's done is obviously a different matter. But what role does the Dementia Network have in actually pushing that in terms of NHS England?
Oh, we are going to push it, and you're going to help us push it by the outcome of today's workshop. Okay, so thank you. So we've got 3 issues there. I won't repeat the questions. Let's see if we can pick them all off between the 4 of you in the next minute or 2.
I might respond to the one about culture. Because although in this pilot we had mostly white British, I have worked in Islington, which is very diverse. And what's really important is firstly that you understand your community, because with a lot of these ethnic groups, they seek help very late. And just having an understanding of that and making sure there's something in the community to meet the needs of the people. So just being very mindful of what is available in the community for the different ethnic groups. The other one was...
Well, I'll just say very quickly that just to make sure that the review is personalized and individualized, and you just ask people what their needs are directly and try and explore, whatever it is that they might be best supported with. So I think that's really, really important.
Chris, I saw it. Okay.
Yeah, I too also work in a very ethnically diverse community, and I would second what Helen said. I think what's most important is to improve equity of access. Because of the time frame of this project, we went with a practice who was willing to host us, and that practice is an excellent practice. We did approach other practices as well in setting more diverse communities. But again, you must remember that this is a feasibility project that we piloted in the first instance. But absolutely, it's key to recognise dementia in people from diverse backgrounds and provide them with, I guess, the space to feel safe to come forward and shake off that stigma of coming forward. And that's, I guess, what we're trying to embed, that connection with the community. I think you also asked about costings as well. So as Jeremy said, we really hope you'll help us drive this forward.
Ben, did you want to come up?
And just with regards to the question about carer centres are really well connected to their local communities. And one of the things that came through from the pilot were people saying we need a curated list a directory of what's available, what's out there. I think it's really useful for the carer centres to try and have regular meetups with the practice managers of GP surgeries and try to ensure that happens. And I think there's a responsibility on both sides to try and make sure that this happens, to build up that community knowledge about what's available locally. It's not easier said than done.
Does anyone want to pick up the question about someone wants to know what mental health interventions did you make off the back of the reviews?
I'll pass it to the people who did the reviews.
So there was support for the carer
And the patient.
and the patients.
In what form? Was it sort of recommending a prescription? Was it wanting someone to need get a psychotherapy referral? What sort of interventions do you remember? There were a few.
I think it was mostly referring to the in-house mental health professional. I think that was the majority. So it probably would have been referral for therapy, talking therapy, if that hadn't been available. I think that was the most common mental health referral.
Okay, great. Thank you. So apologies, I've run 6 minutes into Laura's time, for which I apologise. But this is where we're just going to pause for like 10 seconds. We'll let you guys go. Thank you very much. And now it's my great pleasure to introduce Laura Cook, who's the project lead at the network, London Dementia Network, who's going to lead us into the workshop part of the afternoon. So Laura, over to you.